How many hours a week are you putting in this role as commissioner?
Well, at least 10 to 12, 7 days a week. Ask Margie.
Yes.
Yeah.
Yep.
We just work like there's no tomorrow, including the deputy commissioners.
Yep.
It's probably not healthy.
As commissioner?
Well, at least 10 to 12, 7 days a week. Ask Margie.
Yes. Yes.
Yeah.
Many people in New Zealand do have 2 jobs and they work more than 8 hours a day. That's quite normal for many New Zealanders who are working incredibly hard.
Do you believe someone like Mr. Levy should be giving the commissioner role their full, undivided attention?
Absolutely. Yeah, I don't think it's a part-time role. I mean, he is now responsible for running the entire hospital system across the country. That is a full-time job.
Given the challenges facing Health NZ though, shouldn't this job be consuming your full attention?
Well, the job is never put as a full-time job, but I would propose to you if you're working 10 to 12 hours a day on a particular job, that's quite a lot.
Why would you charge 320 grand a year for not a full-time job?
I don't charge anything. That is the way that the job has been set up. Same as when I was the chair, that was about a 2.5 to 3 day a week role.
Those I just might say those fees are set by Public Service Commission, Ministry of Health.
Will Health New Zealand start publishing minutes and agendas and papers of commissioner meetings as occurred when Health New Zealand had a board?
We've not yet contemplated that because it's all pretty new, but it's certainly something we would give strong consideration to and let you know shortly.
Which leads me to my final question. Is the use of non-disclosure agreements, as is currently being reported in Health New Zealand, in the spirit of transparency and the expectations of public sector organisations? And if you don't mind, how many of the staff accompanying you today are under non-disclosure agreements?
Okay, so I'll just open that up and then ask Margie to talk more about it. There are non-disclosure agreements. I wasn't aware of those when I first came in. I have said publicly in an interview that it's not something that I would do. I would just rely on the normal provisions that we have. I have no idea if anybody here has signed an NDA. I do not request anyone to sign an NDA and don't intend to, but there have been NDAs and Margie's quite happy to answer that question.
So NDAs are a normal part of our organisation. We use them in a number of business practices, including, for example, procurement processes. I did ask for NDAs among senior managers who were involved in budgets, and again, that's not unusual. And as with any normal budget process, I did ask and suggest. I didn't dictate, or I left that to management, executive leaders to decide, so that we were able to get people working on the budget process and be assured that we were able to exchange ideas freely and frankly to be able to give advice.
I can advise members of the Health New Zealand delegation that this is a highly unusual practice in a public sector organisation. And I put to you, Commissioner Levy, you have the power to ask for these to be removed. And in fact, the Public Service Commissioner has asked that I put to you this issue about whether you think this is appropriate in a public sector organisation. I have seen some of these non-disclosure agreements. They ask officials not to discuss their ideas. This is North Korean, get rid of it.
So excuse me, I have seen that request and I am responding to it. Been in the role of Commissioner about 2 months and was the chair for a short time prior to that. Would be obviously keen to answer your questions. The financial position is quite precarious. It kind of materialised suddenly a run rate deficit in the order of 130 to 140 million per month. But the reality for us, if we don't actually address that issue, which is a expenditure beyond budget issue, it keeps getting cast as cost savings or cost out. All we're actually doing is actually trying to get back to budget, the fundamental discipline of any organisation from a financial perspective. So we're taking many steps right at the moment in order to reduce that run rate deficit. If that run rate deficit was not reduced, by the end of this financial year, we would have a deficit in the order of 1.4 billion. We need to, as I said before, we need to get the most out of the resources that we actually have. I know there's always the argument about the amount of resources, and that's all fine, but actually we've got a lot of resource and we're not actually getting the true value out of that resource, and we need to do that, and we're working to do that, and we're actually starting to see the first flicker, I emphasize flicker, of productivity uplift. And that's what we want to do, because if we can get the productivity up, do more in the resources we have, we can start getting those waiting times down. That is the actual real mission here, to get waiting times down to levels that are acceptable, because currently they're not acceptable. Some of us, and Margie and I, in that sort of cohort, we've been through this before. I'm always reminded I was chair of Waitemata when our 6-hour target was 61%, the worst in the whole country. And in about 18 months or so, we got that to 90, and some months after that to 95. My main memory about that is the very same people who delivered the 61% result were almost to a person the very same people who delivered the 95%. Okay, so if people ask, is this possible? Yes, it is possible, but it isn't simple. It's a very disciplined process, and it does take time, but it's definitely possible. But look, I think that primary care is probably shifting towards an interprofessional practice model, and that's likely to be more sustainable. And some practices are going in that direction and others aren't, and not everyone would have to. I think we just have to find out the mechanism for sustainability. And at the moment, there's a lot of issues there, and we need to find a way actually of making that sector or helping that sector work better. Don't know what all the answers are, but sometimes we do need to move towards new models. And, you know, I see a number of practice groups that have interprofessional practice, where they have general practitioners, where they have nurse practitioners, nurse prescribers, pharmacy prescribers, health coaches. You know, there's almost every type of person that you can think of. And that kind of practice seems to be, you know, working quite well and possibly sustainable. But in the end, you know, it's not for us to solve all of these problems. As I said, in the end, I believe in that we need to do much more co-design. Problem about co-design is you give up control. Well, that's no longer a big issue for us, because we don't want to control everything. We want to just get good outcomes. So I see a lot more working together with primary sector to work out, and some proof of concept pilots, trying different things. You know, I think we need a lot more of that myself.
So I'll just add that we know that the funding model doesn't necessarily fit the kind of models that primary care, and we know lots of practices are, you know, building multidisciplinary teams. It doesn't help us with urgent care or after hours. So we know that there are bits of access that the current capitation model isn't fit for purpose, but we are working with the Ministry of Health. We also have undertaken some work to check whether we should be reweighting the capitation formula. So we've got some advice being formed around that. So certainly we accept that actually the model does limit, you know, expanding what primary care can do. But we've got some advice underway with the Ministry of Health.
And it's probably a bit constrained around the complex patient as well.
Yes.
You know, so I think there's a lot of different possibilities there, you know.